next topic. I would like to invite Dr. Tulika CHAUHAN next, who is the chief instructor for our course today. And she's going to be talking about the future of these specialty contact lenses with us. Dr. Tulika, ma'am, please.
Thank you, Dr. Kangsha. A very pleasant morning to all of you. I am Dr. Tulika. I will be covering what's new. What Dr. Krishna has spoken about is something which we do in our day-to-day practice. So do we need something new? Because according to him or other speakers, what we are doing is perfect. So are we perfect right now? And if we are perfect, then what is the need of new? So when we question this, that we need something new, that means the existing technologies might not be perfect. So, as an ophthalmologist, when I'm taking care of diseased ocular surface, my aim is to align curve of the contact lens with the diseased ocular surface. But we all know that contact lens bound to move on the surface. It works very well on the surface which are healthy, but will it work on the surface which is unhealthy? So, what method we are using is called trial and error in India, which is very prominent, very dominant in India. But what will happen? Multiple trial and errors, unhappy patient, disappointed doctors, right? So that is why we need something new. So we need a custom fit. So I just wanted to tell you that why I need a custom fit for my patients. Because ocular surface elevations, when you see ocular surface disease patient, you won't find a normal ocular surface. We will find ocular surface elevation in form of pinguicula, pterygium, irregular corneal grafts, Salzmann nodal degeneration, and other nodal degeneration as well. Post-surgical patients like filtering blebs, tube shunts. So what it does, if we use a trial and error method, then what will happen? We do a lot of lens modifications, like we do a lot of notchings and peripheral lens elevations, quadrant-specific design or truncations. That means your patient is coming again and again to you, right? So what custom fit avoids? It avoids reordering of lenses, it avoids remake of lenses, and it avoids non-revenue follow-ups, because your time is precious and the patient time is precious as well. So that's why we need a custom fit for each eye. So we'll discuss what is new right now in contact lenses. I'll be covering predominantly scleral contact lens, which we practice in our day-to-day practice. So there are two technologies. Very important is empirical techniques, which cover corneoscleral profilometry. The instrument used for this are scleral topography, corneoscleral topography, corneal tomography, ASOCT. And the future is Wavefront custom specialty contact lenses. So this technology we might not have everywhere freely available in India, but in Europe they are using it a lot for customizing the specialty contact lens. The second technology which is very popular, which is about to come to India very soon, is impression-based technology. It is custom mold. Predominant market is Eyeprint prosthetics. We'll cover the impression-based technology. What it does, it takes a globe impression. So the process involved, we take a globe impression with a molding material. It make a digital model of the eye using the 3D scanner, and the scleral lens is designed with a proprietary software based on ocular elevation, measured by impression mold. This creates a highly customized and incredibly specific, comfortable, and stable scleral lens for the patient. So Eyeprint prosthetic is FDA approved, and they make 3 kinds of lenses. The first 2 lenses, which I'm going to discuss here, they are based on the impression technology. So Eyeprint Pro is the lens, which is the exact replica of your ocular surface, and it works wonderfully well with the very diseased ocular surface, whether you have a filtering bleb, you have any nodal degeneration, shunt, and even simplifron. The second lens, which is iFit Pro lens, which creates exact replica, but it is recommended for the less diseased ocular surface like post-traumatic ocular surfaces, irregular corneal transplant, and small Salzmann nodular degenerations. Third lens, which is very popular, which I'm covering here because it works with empirical technology. It doesn't take impression glow, but it works with the scleral topography. But because it is marketed by Eyeprint prosthetic, I'm mentioning this here. So it also makes a ocular surface replica, but it works with the scleral topographers. So what Eyeprint does, they use oxygen permeable material, high decay material, which vaults the cornea, and the lens land on the sclera, so it's a scleral lenses, and they use the elevation-specific technology using a molding material. And this coating is tangible hydra so that there is no deposition on the lenses. And they take the impression. This impression will go to the lab, where with a 3D scanner, they make a digital print of the eye, and they design the perfect lens for the patient. So how we do it in the clinic? So this is not my personal video. This video is taken from the Eyeprint Pro. So this is a molding material, which is inert in the eye. We take the impression, and we get this 3D scanner digital print of the eye, and this print is sent to the lab. And there are the software where the documents are added, and the patient's measurements are added, and they end up making the lens. So how it helps? It decreases the remakes, because you have exact replica of your ocular surface, so you're going to make a perfect lens for the patient. So this is how the mold looks like after you take it from the eye, and this mold will go to the lab. So empirical techniques. Empirical techniques are very important. Why? Because it doesn't touch your eye. It is not going to put any material in your eye, so patients are very comfortable. It's not an invasive procedure. So what we do in empirical techniques, we do ocular surface profilometry. If we have a profile of the whole ocular surface, we are able to make a perfect lens for the patient. So why it is important to have ocular surface profilometry? As far as scleral surface is concerned, we are not sure whether our sclera is spherical, toric, or asymmetrical. And as we know from the studies, that scleral asymmetry topography is independent on your corneal counterpart. Your cornea will not reflect your scleral topography. And we all know why we need corneal surface. We need to know the irregularities on the cornea, because that's what we are going to overcome through these lenses. So it can be in the form of astigmatism, it can be in the form of elevations, it can be in the form of distortions. So the scleral topography is something which I want to cover here, because these scleral topographies are used to customize the lenses these days. So it replaces the trial and error method which we used in our day-to-day practice. It makes the fitting faster, it saves the chair time, reorders, remakes, follow-ups, and scleral surface mapping will lead to the custom design lens unique to that particular eye. So mapping technique use reflection-based system with projected pattern sequence to map the cornea and the scleral surface. And this projection comes from using fluorescein to the ocular surface. With lid retraction and the eye excursion, profilometry techniques are capable of imaging beyond 20 millimeter scleral cord. So immediately detect the need of toric landing zone and how much toricity is needed to optimize it. So current topographers which are available in the market, unfortunately not in India, but yeah, they are available. So one is S-MAP 3D. It is from Visionary Optic. It takes 1 million data points on the ocular surface. It covers almost 22 millimeter of sclera with a precision of 10 micron. It uses sodium fluorescein for the image acquisition, for the projection, and it takes image in 3 gazes: straight, up gaze, and down gaze. The only drawback of this instrument is that it stitches all the 3 images to make an ocular surface profile. So then, to overcome this, this is a video from 3D mapping. So that's how it profiled the sclera. It takes almost 22 millimeters of sclera and profile it for us. And this data will go to the lab. These measurements will go to the lab for the customization of the lenses. So because it stitches the images, there are chances of error. So this eye surface profiler is from Eagle Eye. This is, again, a scleral topographer available. It takes 3,000 to 500,000 data points. It covers almost 20 millimeter diameter of sclera. It also uses impression technology for image acquisition. But the best point is it takes single image in primary gaze. And the device will automatically generate the best fit lens design. In this instrument, it will suggest that what would be the lens algorithm and which lab works on these algorithms. And you can directly send the data through this machine. I'll show you the video here. So this is the image acquisition by Fourier transformation. It just read 500,000 data points. We just put a fluorescent, and this scleral profilometry comes. And on the basis of that, it gives you first lens algorithm and the suggestion that which lab will make this algorithm for you. And through the direct connect, though we don't have it in India, but this software can send this data to the company, and the lens can be made from the lab. Another thing, if you don't have scleral topographer, if you don't have a very great scleral lens practice, so scleral topographer will be very expensive. So in India, what works for us is corneal tomography. So the Pantacam. So Pantacam, not every model, but some model of Pantacam have corneoscleral profile module. So it maps the sclera as well as cornea. It acquires 250 points, 100,000 data points, 250 images of 100,000 data points. But it again takes images in 5 gauges, and they stitch those images and make the ocular surface. Anterior segment OCT, as Dr. Krishna also covered, is very helpful to see the clearance in micron because it does not cover that much sclera. So Pantacam works better for us in our day-to-day practice rather than anterior segment OCT. But if it is available, it helps to profile the surface. So the limitation is it measures sclera and the static surface of the its static surface. But the eureka points are there. Why scleral topographer is so popular with the scleral lens practitioner? Because it creates the free-form lenses. Free-form lenses, that means you can optimize and customize lens according to the ocular surface. Asymmetric lenses with multiple meridian of toricity or highly irregular surface. Vault pathologic elevation without sacrificing other parameters such as diameter or base curve. And the freedom from complicated lens modification as notching or truncation. When we do assumption, truncation, or notching, we might end up making not the great lens for the patient. It is not custom fit for that eye. So that means scleral topographer help us to avoid those things. We can combine these technologies. For example, if we have the irregular pupil or abnormal visual axis, what we can do? We can use a decentered optics with scleral profilometry, and we can design a lens in which we have a decentered optics and patient can have a better vision. Aberrometry with ocular surface profilometer is a great combination. Optivis is the company which is providing this combination these days. And ocular surface condition lead to increased higher order aberration. Free-form lenses can neutralize the higher order aberrations. So Wavefront guided custom fit is important because Wavefront guided custom lens technology is designed to specifically target the unique aberration of individual eye, particularly the elevated levels of residual aberration experienced by highly aberrated eye wearing conventional contact lens. So what it does, this is a machine marketed by OVETS. They check the wavefront of the eye, they check the aberration of the eye, and these aberrations was charted, and they were embedded in the lens, what they design here. So these lenses will overcome higher order aberration in the patients. So the pinnacle point would be in scleral lens when we can customize best optical and visual performance for every eye. So this is from my side. Thank you very much.